I'm audible? Okay. So, welcome you all, whosoever is there present in the hall, to this session on how we can improve our cataract surgery result by advanced diagnostics with the use of ray tracing aberrometry. So, as we know, cataract is the most common refractive surgery being done today world over, and the vision is much more than Snellen 6 vision. It involves contrast sensitivity, a vision without glare and halos, a good mesopic and scotopic vision, and so this diagnostics by eye trace help us to achieve all these things by incorporating the findings in the diagnostic various charts, how we can plan our even a monofocal or a aspheric IOL or a toric IOL, multifocal or EDOF, you name anything, because the last two lines are beyond the 2020 Snell's vision. The higher order aberrations accounts for around 0.25 diopters of refractive error, and that amounts to last two lines in terms of quality of vision. So we have a galaxy of speakers in this instruction course. All of them doesn't need an introduction. The first talk will be by Professor Chintan Malhotra. She is a professor at PGI. She is doing great work in cornea, cataract, and refractive surgery for last more than 15 years, and she will help us making us understand the basics of eye trace machine so that we can then build upon that how to use that information in improving the outcome of various aspheric, monofocal, EDOF, multifocal, and toric IOLs. Dr. Chintan.
Thank you very much, sir, and a very good morning to all present. So my talk, as Professor Jain mentioned, is about ray tracing aberrometry with the eye trace. I'll be sticking to the real basics. This talk is basically for somebody who is not really familiar with what an eye trace is, and so it help. I hope that it will help to understand the concepts of what we are looking for, and then the subsequent speakers will be talking about each of the functions of the eye trace. So the eye trace is basically a 5-in-1 technology. It is a wavefront aberrometer. So it measures the wavefront coming out of the eye to measure what are the imperfections in our eye. It is incorporated or combined with a placido-based corneal topographer, which measures the aberrations from the cornea and also tells us about the topography of the cornea. It also has an auto refractor, and the advantage of this is that it gives us multi-zone refraction in different zones like 4 pupil, 6 pupil. So that helps us to know what the refraction the patient has in mesopic conditions vis-a-vis scotopic conditions. It is an autokeratometer, and of course, it is a pupillometer. So the principle of ray tracing is that it uses near infrared beam of laser beams, and 64 beams are projected sequentially 4 times at different locations on the retina. So, what I mean by sequential is that one laser beam goes, then the other goes, then the other goes. They are not projected simultaneously. And since they are projected 4 times, so we have 256 points which are mapped. The advantage of this sequential projection is that in highly aberrated eyes, for example, in keratoconic eyes or irregular corneas, the data confusion is minimized. And that's why it is able to capture reliable data despite there being a lot of noise in the data per se. So the beam pattern can be scaled to pass through variably sized pupils. It can be scaled to pass, and that does it automatically through a 2 pupil vis-a-vis an 8 pupil also. And so that again tells us about how the eye is behaving in different conditions. The retinal positions of all these rays that are going into the eye are mapped to form a retinal spot diagram, which is seen at this bottom. This is a retinal spot diagram. And the rays which come back from this, that is known as the emergent wavefront. That is what is actually mapped as the ocular wavefront. And the deviation of the emergent wavefront. So we have mapped what is going in. We already know what is going in and where it landed. And then we measure that whatever was coming out, how much is it has it shifted from what was originally sent in, or how pure or impure are the quality of our vision is. And that's how we get the ocular aberrations. Now, before we go on to this, because it shows a lot of data points, we have to check the reliability of the data acquired. And for that, before we see anything, we should see the wavefront verification display, because it helps to verify the integrity of the data. For this, we look at the top left-hand screen where one can see that yellow circle. If more than 10 points are shown as rejected, it states that the reliability is questionable and the map should be acquired again. The lesser the number of points rejected, for example, you see these clean peaks, and this is obviously a very good retinal data, and this is a minimally aberrated eye. We all know that the eye has imperfections, so it can never be a complete circle. A circle is projected in, but we will never get a circle out. Sorry. So, in an eye with minimal aberrations, all 256 spots should fall on the retina, and the retinal spot diagram should be a closely packed cluster, a perfect circle. But, like I mentioned, we already know that the human eye is really perfect. So, even this map at the bottom is a good spot diagram. It shows an eye with minimal aberrations. The point is that the retinal spot diagram should not have large areas of discontinuity. Then we see this map on the right of your screen. Now, this is zigzag, but this is not unreliable data. It is just because we see the verification displays again showing that just 1 point was rejected. So this just shows us that the optics of the eye is not good, not that the data is not reliable. So that's the importance of looking at the verification display. Now, what does the eye trace actually measure? So it measures the total imperfections of the eye, that is your total aberrations. The corneal data we get from the placido-based topography. The wavefront we map from the infrared laser beams which are going in. And then the internal aberrations we get from the total, that is the total wavefront minus the corneal. And the internal are usually attributed to disorders of the lens, although they can come from the other structures as well, but mainly it is the internal aberrations could be used interchangeably with the term for the lens. So the ability to separate these lenticular from the corneal aberrations is what makes this technology basically unique, and how the other speakers will be building on it, how we can use it to our and to the patient's advantage. Now, this is the basic display, the Chang analysis, which was given by Dr. Chang, and which is why the name the Chang analysis, and gives us a lot of information. Looks confusing at first, but if you look at it component wise, it's fairly simple. So we have this top right, we have top left, sorry, we have it's showing there the internal, which means that this is showing us the internal aberrations, the lenticular aberrations. So we should start from this actually. We have the total eye aberrations, the different aberrations are given here. I will not go into that. Then you have the internal, which are actually got by subtracting these corneal aberrations from the total eye aberrations. So that means you get the lenticular, you get the corneal. These are separated in this vertical column here. And the red and the blue are opposites. So one from the cornea, usually one will see that something from the cornea in a good eye with good optics, one will cancel out the other so that an eye has minimal aberrations. So that's the corneal aberration. Then we have the axial map at the bottom, which is showing us the topography. And on the sides, we have this zone, which is showing us the refraction. It is showing us what I mentioned, the multi-zone refraction. So you have refractions at different areas. This map is also telling us that this was measured in a maximum pupil diameter of 5.7 millimeters. That's where the data was acquired from. And this sign here means that this is done with spherical correction only, which automatically is being put in, but not with cylindrical correction. If we see this, if this red bar is not here, this red bar, that will mean that we've been doing it with spherical and cylindrical correction. And if we, so that probably we'll see in some of the scans. And I'll come to the other parts of the map later. So, for example, this is a patient being planned for cataract surgery, and we want to decide whether this patient is fit for a toric IOL or not. And if we look at the two boxes outlined in yellow, we see that the corneal aberrations and the total eye aberrations are mirror images of each other. What it means once we have mirror images of each other is that the main source of the aberrations is from the cornea, and we are looking at it that the astigmatism is the main aberration which is there, and the lenticular aberrations are there, but it's minimal. So this is a good patient for a toric IOL. The other advantage that it provides us is that we can, once we have torics and we don't have, this is a post-op thing, if we don't, we want to see what the post-op result is. Suppose the still patient still has a residual cylinder, so this will tell us how much it's off and how much rotating it will help us. So like this is showing us that your corneal and your lenticular wavefront. So this is your intraocular lens in place now. This is our axis of the intraocular lens. This is your corneal thing. So we have to match that. And it's showing us that a 25-degree clockwise rotation will give us a significant change in the cylindrical power. On the other hand, in another example, this is showing that it's a minimal change and there is nothing which is required to be done. So that's a simple way to look at it. Then this is an example which is exactly the opposite situation of what I showed earlier. The yellow bars, the yellow diagram is showing that the total eye and the internal aberrations are exactly mirror images of each other. The cornea is fairly clean, which means that the main source of aberrations is from the lens. And if we look at it, the pathology is predominantly lenticular, like I mentioned. And on slit lamp, I've gone back reverse. Obviously, we would see the patient clinically first, but I've gone back. And on clinical examination, this patient had a very obvious lenticonus, anterior lenticonus, and which is why these aberrations were there. And so we know that the source of aberrations is the lens. If we remove the lens, the aberrations will reduce. So this patient underwent a phacoemulsification, and in fact, he was implanted with a symphony lens because you're confident that the lenticular aberrations you're going to take care of and the cornea is clear. And this is around 4 or 5 years ago, and the patient had a 6/6 visual acuity on day 7 with a minimal cylinder. And we see now again that the internal aberrations have become zero. I mean, they have become so minimal from what the bars were there, and the corneal aberrations are what they were. So because of the removal of the abnormal crystalline lens, the aberrations have become zero. And this again is the visual, how the patient sees. This is a simulated version. This is an excellent display of how the patient can be taught about what their problem is and for us all to see. So the upper column is the pre-op, the later column is the post-op. It shows us that pre-op, again, the quality of vision was this. That was mainly because of the lens. And now this is the post-op quality of vision because the quality of vision of your lens, the intraocular lens, has improved. The corneal aberrations don't show much change, not too much change. So that's how it helps us to understand. Just the last couple of slides from my presentation, it has a lot of other data which we can use. So these value of the atlas rings is a data point to be fed in for the ASCRS calculator while we are using in eyes in post-refractive surgery. That's helpful. We have the effective refractive power that again is useful in deciding the IOL power in cases with post-refractive surgery. We have the corneal spherical aberrations more than zero point 0.3. I'm sure it will be touched upon later. So if the cornea is highly aberrated, we do not want to put in premium multifocal IOLs because then the patient will not have good quality of vision. And the machine itself in different maps also gives you those checks. It will show it in red or yellow, right? And the last is the angle alpha and kappa, which maybe just quickly I'll say. This angle alpha kappa is the distance between the visual axis and the pupillary axis, which is this. Sorry, this is the angle kappa between the pupillary and the visual axis, and angle alpha is the distance between the visual axis and the optical axis. This will be coming in later talks, but it's just that the angle alpha basically tells us the center of the bag, and it tells us where your IOL will center. So if your IOL is too much away from the from the visual axis, then the patient will not have good vision. And so if the angle alpha is more than 0.5 mm, premium IOLs are to be avoided. This is going to be covered in subsequent talks as well, so I've just done that. So just to conclude, an eye trace is basically a technology which we cannot do without if we have to do premium surgeries, premium implant, premium IOLs, as well as in understanding what are the reasons for the patient's other corneal pathologies, and also in analyzing our post-op results. Thank you very much.
Yeah, I think excellent talk. We can have the questions at the end of the presentation because many of your questions will be answered in the subsequent presentations, and we have a lot of time for discussion around 15 to 20 minutes. So we can take up questions at the end of session. So Professor Amit is little away. He forgot to bring his laptop. So I think I'll continue with my talk. I'm going to talk about optimizing the choice of monofocal IOLs, aspheric versus non-aspheric IOLs. Yeah. So as we have already talked, cornea is not a perfect camera. The eye works only at 40% efficiency as compared to an ideal camera, which works at 100% efficiency. The rest of the 60% is aberrated, partly by the optical system of the eye. So all these are neutralized by the neural processing of the retina, optic nerve, and brain. So that's how we get a very clear picture. The picture formed on retina is very crude, for which Hubel and Wiesel got Nobel Prize way back in 1963. If you see that picture, it's very crude, hardly recognizable. So, as she has already highlighted, eye aberrations are total corneal as well as internal optics of the eye contributes to it. And measuring corneal aberration without lens or total aberration is, doesn't mean anything. And we all know that it can be higher order aberration can be classified into Zernike polynomials, but the clinically relevant aberrations are comma and spherical aberration, which we are able to address as of now in the lenses. And lower order aberrations accounts for around 18 to 80 to 90% of the optical defects. Rest of the aberrations, these are the lower order aberrations, and higher order aberrations accounts for around 10 to 20 degree of optical aberrations. There are polynomials which goes up to 64 types of aberrations, but we are mainly concerned with the third and fourth order. Rest of it is, as of now, is noise in the machine. Our machines are not sensitive enough to detect those, and as of now we are addressing only spherical aberration and comma aberration to some extent with few lenses. So uh, okay. So, coming to the spherical aberration, you all know it is of two types, positive and negative spherical aberration. Normal eye has positive spherical aberration, cornea has positive, and the lens has negative in youth of life. As the age advances, the lens also acquire positive spherical aberration, and following a surgery, a LASIK surgery, or we introduce flattening of the cornea, you get a positive spherical aberration is increases. And spherical aberration and defocus aberration are the only aberration centered on the optical system. Rest of the aberrations are in the peripheral part of the system, and only these two have been targeted by aspheric IOLs. And this already highlighted that young eye has positive cornea and a negative crystalline lens aberration, and the total summation is usually to the tune of around plus zero point 0.1 micron. And as we ages, the lens hardens and it changes its aberrations, the spherical one from negative to positive side, and so the total eye aberration becomes positive. This is just to show that once there is a increase in positive spherical aberration, the quality of vision goes down. And so, what is aspheric lens? So, we have to replace this positively aspheric normal human crystalline lens with a youthful crystalline lens which had a negative spherical aberration. That's how the negative aspheric lenses. There are plenty of lenses, aspheric lenses available in the market. They are aspheric neutral also. They have specific indications. So this is two eye of the same patient. In one eye, we put a non-aspheric lens, and in other eye, we put a aspheric lens, which has a asphericity of minus 0.21 micron, which is IQ lens. And you can see the Snell ratio, which is the best marker for quality of vision. In this eye, close to 1 is the best cell ratio which we can achieve. This has only 0.09, and other eye has around 0.92, which is quite close to 0. And you can see the point spread. So again, here you can hardly recognize. Dr. Amit will be highlighting about the modulation transfer function and point spread function. So the fineness is the point, better is the modulation transfer function. So that is the difference between a non-aspheric and aspheric lenses. So spherical aberration will lead to a lot of aberration in the vision in terms of halos, halos and glare, as well as difficulty in night driving. And this is the distribution of spherical aberration with age. As I already told, as we age, the negative aberration of the lens keeps on increasing towards the positive side. And as we ages around beyond 60, total spherical aberration of the eye becomes positive. And these are the various different types of IOLs which are available with different denomination of spherical aberration, and which based on the spherical aberration in the cornea, we can choose an IOL which will lead to a specific type of spherical aberration in tandem with whether we are targeting a plus or a zero or a negative postoperative spherical error. So this is a one study which highlights this. This shows that once we are targeting a defocus of 0 or minus zero point 0.5 or plus zero point 0.5, it is better to have a total ocular spherical aberration to the tune of either minus zero point 0.1 to 0 with zero diopter, or when you are targeting emetropia, or a positive spherical aberration when you are targeting myopia, and a much higher negative, because they act in tandem with the spherical aberration. Because spherical defocus and the spherical aberration, they have a summation effect when they act together, because our eye works as a whole. So this is how different types of how you choose uh, lens of a specific asphericity depending upon the corneal asphericity. That's how you can customize, because on an average corneal aberration is 0.27 micron, but there is a wide range. It varies from zero point 0.1 to zero point 0.4. So if a person is zero point 0.4 micron of positive spherical aberration, you will like to choose a IOL with much higher spherical negative spherical aberration, that is 0.27 micron minus, that is techniques. So based on that, you can choose an IOL, or depending on the target defocus you are choosing. So there are various studies in literature which tells us that using aspheric lenses increases the quality of vision. And how to go about it? So you have to evaluate the optical alignment with angle alpha, as dr first, this is the examination part, as Dr. Chintan has already highlighted. If there is a high angle alpha, consider a monofocal IOL. As she already told, don't try to put a multifocal IOL. If the angle alpha is not high, then we have to analyze the corneal aberration with Chang analysis, which already, and DLI. I'll come to this later on in the last talk. Dysfunctional lens index. This is a new term basically used for presbyopia. And if the aberrations are low, or if they are not low or they are high, again use monofocal. If they are lesser, and patient needs a toric, then go about a toric IOL. And if the aberrations are high, then I mean, if the angle alpha is low and patient is uh, non-toric, you continue with multifocal or a premium IOL. So this is again a repetition of the same thing. This is a patient of cataract which is showing high internal aberration. The DLI is to the tune of 0.85. Anything less than 5 becomes an indication for doing a cataract surgery, though the angle alpha is all right. So this is the quality of vision. Corneal clarity is quite good. And this is the Chang analysis. I won't go into detail, already highlighted. And angle alpha already she has told, up to the range up to zero point 0.3 is okay, zero point 0.3 to 5 is borderline, more than 0.5 millimeter is higher. One should not use multifocal IOL. And so this is about the modulation transfer function. Again, Dr. Amit will be highlighting this. Just to highlight this, this is an internal modulation transfer function. Because the cataract, it should be normally more than 40% at this 10 decibel. That is what the eye is efficiently working, 40% efficiency. All right. So following the cataract surgery, this is the same patient. Following cataract surgery, now you can see the aberrations have decreased quite a lot. Already Dr. Chintan has highlighted. and the quality of vision improves, and the DLI also improves, and the modulation transfer function also improves, the internal one, because previously it was very low. Now it's to the tune of almost 60% post operatively. That's how you read it. And again, this talking about angle alpha. Here, the angle alpha is very high, 0.71. Okay, so it's a contraindication for doing a multifocal IOL. And this is another patient where the internal DLI is not only based on the opacification of the lens, it is also based on aberration in the internal eye, like she highlighted the lenticonus patient. All right, the corneal aberration will increase in a keratoconus patient. So, if sometime even if the cornea is clear, you have internal higher order aberration. So, those are the patients we are not talking about, which are sort of in contraindication for doing a corneal based refractive surgery or even doing a ICL, because their vision will not be good enough. Uh, so here is a patient where this is the IOL selection map. It gives everything about the uh, uh, astigmatism. It tells us about whether the higher order aberrations are there or not, whether the angle alpha is within the limit. So if everything is normal and the aspherate is, it will automatically tell us which lens to use. But here the DLI was good enough. There is no indication for doing cataract surgery. So this is another patient where the angle alpha is within normal limits, and angle alpha is also okay, and there is a not very high astigmatism. Asphericity is also within, so you can go ahead with any of the premium oil or toric oil, depending upon whether the astigmatism is there or not. So you can see this is the pre-op. Here we have used eye-enhanced lens. Here the pre-op spherical aberration total is very high, to the tune of 0.27. All right, and but post-operatively it has decreased too much, because here we are using a IHANS, which is a Technis platform, which has a sphericity of 0.27. That's how you improve the results in a case of given case, and you can customize the cataract surgery even in monofocals. And aspheric neutral IOLs we should be using where you are expecting some pseudo exfoliation, where the decentration of the lens is expected. Thank you so much. Now I'll invite Professor Rajesh Tityal. He doesn't need an introduction. Everybody is knows him. He will talk about because Dr. Tityal again will come later on. He will talk about the use of eye trace parameters uh, in choice of multifocal, when to choose multifocal and when not to choose multifocal. So it's a very versatile machine. If we use it, tells us so many things. We can really improve the quality of vision in our patients. And it goes without saying that, of course, we have to check ocular surface should be normal in all these cases. Otherwise, because all these higher order aberration are in terms of decimals of micron. And if our tear film is not good, it, it doesn't mean anything. We have to have a very pristine corneal surface to address higher order aberrations. Thank you.
Thank you, sir, for the opportunity. And I must say that this is a very specialized IC, wherein we have, in order to improve the outcome of cataract surgery, in order to improve the outcome of refractive surgery. These days, people have started feeling that the eye trace has a great role to play. So I'll be talking about selecting patients for multifocal implant based on eye trace. And we all know that for success of multifocal implant, patient selection is very important. We have to see to it that the patient is not very finicky and not very too demanding. The biometry has to be accurate. Good, accurate IOL power calculation should be done, and proper surgical technique. And one should avoid when the patient is too demanding, has unrealistic expectations, Occupational night drivers, they may have problem, because most of these multifocals these days that we are using are mostly these trifocals, etc., and all these have these rings, refractive rings that are present, and that can create problems. And very high corneal astigmatism, little bit of corneal astigmatism is manageable because now we have multifocal torics, but very high corneal astigmatism does require some you have to have some degree of suspicion in order to see to it, to rule out certain corneal pathologies. Then any pre-existing ocular pathology, previous history of refractive surgery, I'll be a little hesitant in putting any multifocal implant unless the patient is asking for it. And of course, somebody who is having diabetic retinopathy, it should be avoided. And most of the dissatisfaction that happens with multifocal implant is because of the IOL misalignment, improper selection. Uh, there is posterior capsular opacification. Patient has poor ocular surface, as Dr. Jain sir was mentioning. Poor ocular surface will have, again, they will have aberrations related to cornea. So dry eye disease, again, is something which should be avoided. And in addition, a large deviation, as we have been talking about in the last two talks, a large deviation between the optical center and the visual axis, like the optical axis and the like center of the limbus and the visual axis. That is angle alpha. And if it's large, then we should avoid. How much large? I'll just come to that. So iTrace has a role to play because this is the tool which gives you the idea about angle alpha. And angle kappa is important in refractive surgery. Why? Because whenever you do a treatment, you do based on the pupil tracking, and it is angle kappa is the angle between the pupillary axis and the visual axis. While so because you treat it based on the pupillary center, you track it. But when you are putting the IOL is centered at along the center of the limbus, that is along the center of the bag, and that is the optical axis. So that is why that is angle alpha, the angle between the visual axis and the optical axis, and that's why that is important. So let's see how iTrace helps. Some very good pictures of Dr. Chintan I could see, wherein she has very nicely presented that iTrace can differentiate aberrations of cornea and internal aberrations. And if you have high internal aberrations, then you can go ahead and put an IOL, which is any IOL that you want. It can be multifocal, it can be anything. But if the corneal aberrations are high, you have to avoid it, and that is what iTrace does. So, for example, if it's a high corneal higher order aberrations in comparison to internal higher order aberrations, in such a case, one should avoid putting multifocal lens. But if somebody has a high internal higher order aberrations, as you can see here, high internal aberrations, and this is the total aberration. So the high internal aberrations are reflected into the total aberrations. The corneal aberrations are negligible. So in such case, remove the lens, the aberrations will be off, so you can very well put a multifocal implant. Same another example wherein the internal aberrations is showing. I mean, there are various ways of depicting when you are recording and when you are interpreting eye trace. So internal aberrations are high, you can go ahead and put a multifocal implant. Another issue is dry eye. Dry eye can create aberrations by itself, corneal aberrations. And if there is dry eye, there will be you have to do eye trace to look for the internal aberration, look for the corneal aberrations. And if the corneal aberrations are high, one should avoid. One should treat dry eye first and then go ahead and do it. So dry eye management, and you have to explain to the patient, maybe wait for some time. If the patient asks for a multifocal implant, explain to the patient, treat dry eye, and then you can definitely give an multifocal implant. Another important thing is optical alignment. Why do you have aberrations? What is angle alpha? Why it creates problems? You can see in this picture, this is a central optical cylinder, and the rays have to fall in the central optical cylinder. And if the angle alpha is less than half of the size of the central optical cylinder, then you can put the multifocal implant. Why? Because if it's higher than that, then these will get refracted from these diffractive plates which are surrounding the central optical cylinder, and that is why there will be aberrations. So, as I mentioned, angle eye trace measures angle alpha, and this is this gives you the idea to decide regarding whether we should implant multifocal implant or not. As I said, angle alpha, if it is high, then the rays will be diffracted from the diffractive plates within the diffractive rings, and that results in creation of aberrations. And that is why it has been, in general, the consensus is that angle alpha, if it's less than 0.3, then you get it in green. If it is 0.3 to 0.5, it is yellow, and greater than 0.5 is red. That is suggestive of an issue that you cannot implant multifocal implant. Now, the question here is that earlier we used to have these multifocal lenses wherein the central optical cylinder was smaller. It was 0.8. Now, in a couple of lenses, now the central optical cylinder has increased. It has gone to 1.2, 1.4, and that is why we have got that extra leverage. We can, even if somebody has an angle alpha of 0.5, if the central optical cylinder is 1.2, then you can implant a multifocal implant. So that is what we have to understand. We have to interpret eye trace, but we also have to understand the morphology and the structure, the anatomy of the intraocular lens that we are implanting. This was one study which was done to look for average angle alpha in a large cohort of patients, and they found out that angle alpha is predominantly a horizontal phenomenon with a mean expected point of IOL centration 0.44 millimeter temporal to the visual axis. So on an average, this was the value, and most of the multifocal implants now have a central optical cylinder of more than one. So that way it is reasonably safe. But yes, we do get cases where an angle alpha is 0.6, 0.7. Just recently in my last OR, I had a patient very much wanting for multifocal, but had angle alpha of 0.678. So I explained, and then the surgery was not done. Again, IOL centration is important. When you are placing the IOL should be well centered. You should see that these Purkinje images are falling right in the center. And this is what I was talking about, that this group has suggested that the multifocal implant should not be implanted if the preoperative angle alpha is larger than 1/2 of the diameter of the central optical region of multifocal IOL. And as I said, now this is an example of angle alpha 0.44. You can place the IOL. Angle alpha 0.394, you can place a multifocal implant. An angle alpha of 0.098, I'm a good candidate again. So in conclusion, if you have eye trace is a good tool, definitely a tool which is expensive, but it does give that finer nuances of selecting patients for multifocal implant in order to have a good outcome. Why? Because multifocal implantation is a tricky situation. Not as far as implantation is concerned, but as far as the optical outcome, visual outcome is concerned. So it can be very satisfying, the patient can be very happy, or if there are aberrations, the patient can be very, very nasty. So eye trace is a good tool for proper planning for selecting a multifocal implant. Thank you very much.
Thank you, Dr. Rajesh, for excellent talk and the substance of the talk. I think, yeah.
It is reasonably accurate because it has been noted in studies that based on this, there are multiple studies now, and they have shown that the outcome was dependent on angle alpha. Higher angle alpha had a poor outcome. Post-operatively, also they have evaluated these patients. So it is considered as reasonably accurate, but it will be nothing is 100% in medicine. Maybe at a later date we can have another machine which can even be more precise and give even some more insight into this. But till date, iTrace is the tool which gives you a reasonably good angle alpha, and based on physics, based on geometry, based on studies, it has been shown that the angle alpha should be less than half of the central optical cylinder.
Yeah, that's a very valid point, but one should be aware also that the angle kappa changes post-operatively also, because there's a slight shift of pupil nasally after the surgery once the volume in the eye of the lens comes down. So there's a lot of variability, but these are the guidelines as of now. And there are few IOLs, as you have already highlighted, which has a larger cylinder size of 1.2 or 1.4, which are more forgiving as far as angle alpha is concerned.
Sorry,
Yeah.
Rajesh. So you showed a couple of slides which were depicting the dry eye,
Yeah.
and there were hardly any corneal abrasions there.
Yeah, no. Actually, what happens that even if there is slight corneal aberration that is present, then post cataract surgery, it has been noted that the dryness increases. Actually, the slides that I showed was initially the corneal aberrations were lesser. Post operatively, it increased the corneal aberrations. So, in such cases, patient can be a bit dissatisfied. So, that is what we have to see to it, that corneal aberrations because of dry eye should not be there, and ocular surface has to be reviewed properly.
And what is the scenario with the newer lenses like the Vivity and the extended depth of focus now?
We can keep getting newer lenses wherein the claims will be higher that it is more forgiving, but I mean, this is what we till date we have to follow, and particularly in any lens which has either extended foci or multiple foci. The surface, ocular surface, plays a great role for any lens. Yes, for extended foci, the it is more forgiving because you don't have multiple foci. This is an extended focal length. But in all these cases, wherever I mean, you have a poor ocular surface, multifocals or trifocals or whatever, these lenses,
Uh,
they do have some issue,
I
definitely.
think that's not the area of focus of this IC. And as far as read of IOLs are concerned, again in them also angle alpha is of importance, because until and unless the EDOF is aspheric neutral, because the asphericity itself leads to a lot of induction of aberration once there is a decentration. Higher is the asphericity, higher is the induction of more secondary aberrations. So as far as EDOF firewalls are also concerned,
Yeah.
the angle alpha holds true until and unless it's a aspheric neutral lens.
And many of these EDOF lenses, they do have diffractive rings.
Yeah.
So
So again, it comes to same thing. There's a
yeah.
four principles on which different EDOFs are based. So the simplest is pinhole, where the decentration doesn't have much effect. So I think we can move on. We can have a discussion if we are left with the time. Now we have Dr. Tityal, who will highlight the use of eye trace and toric IOL management.
Good morning, friends, and thank you, Professor Arun, for involving me in this interesting instruction course. We are talking on some diagnostic tools which are at higher platforms because may not be accessible to common people here. But why should we talk in such a way to propagate instrument like this, equipment like this, which talks about higher order aberrations in cataract surgery? Because we all know cataract surgery now has become a refractive cataract surgery. So you have to acquire devices, tools which can give you a more precision in terms of selection of patients, in terms of giving a good intra-op results and managing post-op problems of these patients also. So which are those devices going to give all these things also? Toric intraocular lenses is part of a cataract surgery. You can't say toric is a premium IOL nowadays. It is a part of a cataract surgery. In fact, almost 50 to 60% of cases would require a toric IOL implantation. If you take one diopter as a cutoff, around 30 to 40%, If you take cutoff as a 0.75, then almost 60% of patient would require a toric IOLs. Now with the trifocal lenses, EDOF lenses, the acceptance of a toric is less than one diopter. Even I have patient with a 0.5, 0.6 also. They may require a toric implantation because that's going to improve your quality of vision for your patient. So the toric IOL is one of the important gametes of cataract surgery. We talked about eye trace system, which gives you all three things. It gives you a pre-op analysis of your patient. It can help you in an intra-op assessment also. And most effectively, it gives you a post-op analysis of your patient in a very, very precise manner. I can understand a large number of toric IOL patients may not require a rotation, may not require an assessment because the quality of outcome is always better with the toric lenses. But if you're using a trifocal lenses, yes, there you may have to look for all these areas. We talked about corneal curvature power, angle alpha, the aberrations by which you can, look into your patient. In fact, iTrace was one of the initial devices with us which gave us some sort of correction of your toric markings, which was not available earlier because we acquired iTrace very very early. Then subsequently we had image guided devices coming subsequently also. So this is a very important. You have seen this slide many many times. You separate the internal aberration from the corneal aberrations, and then you can plan accordingly these patients. And angle alpha, Dr. Rajesh highlighted all these points. Inbuilt toric calculators may be there, which can help you in terms of identifying the axis of your implantation. It corrects your implantation axis. It can be your power also if you feed your biometry readings in those areas. So these are two important areas which may be helpful for your patients for getting absolute intra-operative collection also. So what we do normally is to mark physically first with a bubble marker. You can see this by a physical marker. Then subsequently take the patient to eye trace again to see if your markings are correct or not, how much deviation from the initial marking you have, and it gives you a new axis of implantation for your patient. And that you know that you are 10 degree, 5 degree away from the initial physical marking. Accordingly, you can place your marking also. So these are two important pre-op areas which you can assess for your patient and subsequently look for these areas. So I have talked about two important areas. One is looking for a corneal profile, separating the aberration profile from the total internal aberration profile. So those patients where your corneal profile is good, so these are patients you are going to succeed in giving good outcome for your patient. Patient may have only corneal toricity. So you can do a very nice toric IOL and good implantation and good results. But there are patients you don't, if you do a younger patient where you can do refraction also. So you have a refraction showing a two diopter cylinder, but if you see the cornea doesn't have a cylinder, that means the lens is compensating there. So you have to be careful in those younger patients. But most cataract patients don't have that dilemma because you can correct very. The other important area for toric implantation is the post-op alignment check. I'm saying check because every patient may not require a rotation, but you have to do check for all your patients. So around less than in my series, it's less than a 1% patient may require rotation sometimes, especially the trifocal lenses. So if you have more than 10 degree rotation, vision less than 6.9, patient not happy with your outcome, then you may require a rotation also. So various lenses are available. People are reported how much rotation these lenses have in the post-op period. It all depends what type of design you're using. So these are open loop L-shaped haptic lenses, which is supposed to be more stable in the back compared to those plate haptic lenses, which may have a more rotation, especially silicone lens in your patient. 1 week post-op may be the good time for a re-rotation in these patients. There are various ways to look into your patient post-op toric implantation and how to judge how much rotation is required, how much correction you'll achieve is the important part for your evaluation for your toric patient. Classically, we do a slit-lamp assessment for these patients. You can do retroillumination photographs, and these photographs and your axis and refraction can be taken in online software, which is www.astigmatisfix.com, where you can get the ultimate outcome. But if you have iTrace with you, you don't have to go in all these areas. Just take the patient to iTrace. It can give you enhancement software. It tells you all the profile also. So all patient needs to be dilated. Before that, you see the uncorrected visual acuity. Perform refraction, see the refractive cylinder error, dilate the pupil, and determine the new IOL axis. If you have these readings, then you can do all these areas. But if you don't have these devices, don't worry. You know that which patient is going to achieve correction after rotation. So this is the sort of a general formula for your patient. Will rotation help in this patient or not? If your spherical equivalent is more than cylindrical error, rotation may not help because spherical error is much more here. So that may be a actual error in your calculation. You see here minus 2.5 spherical and spherical equivalent 2 diopter, the cylinder is less. But if you have a patient where cylindrical error is more than spherical equivalent, rotation might help in these cases. You can see 0.5 spherical with 0.5, 1.5 cylinder. The effective is spherical over 0.5. So this is a patient where you may succeed in these cases. So you can see this is the example here again. -1 spherical and 3 diopter cylinder, and the keratometry cylinder 2 diopters, corneal plane 1 diopter. You can see this patient may not achieve any help by rotation in these patients. So that you have to understand which patient might help in your rotation also. So this is the estimatedfits.com where you can reassess the new axis, the old axis, the amount of power required, and feed that and tells you which is the new axis for your IOL, how much rotation is required, how much correction you'll achieve. So same thing can be achieved in eye trace without any of these helps. So this is what eye trace we have done after toric implantation. You can see it says that 26-degree rotation may be required for this patient, which will correct 1.56 diopters and refractive error will decrease significantly. So this is a patient we may have to rotate where visual acuity may not be better than 6.9 for these patients. So this is the same patient where it tells you that this is the alignment of your patient interoperably. This is the new actual axis. So this lens requires a rotation by 27 degrees, but you can't rotate reverse these J loop lenses. Else you have to rotate entire 154 degree to achieve this correction. So this is another patient, 74-degree rotation. So this normally doesn't happen in your series because even any surgery, you may not make so much a mistake. It may be 10, 15 degrees. So this is a patient, high myopic patient with a large bag. And this is a one-day post-op results. I waited for at least 2 weeks for this patient, then took the patient to rotation. By the time bag will, little get fibrous, you have a more manageable bag and rotate the lens subsequently also. This is my very simple technique for these patients. This is the patient where we implanted the wrong axis because of improper disclosure by the assistant, and I implanted a different axis here. So this rotation, this is a 48 hours after surgery. You can just go the irrigation on, and with your cannula, you can just separate a little addition, maybe then optic haptic junction. Once the bag is open, with the irrigation on, you can just rotate. You don't require a viscoelastic also. So this is when you have a larger than 10-degree rotation. If you're less than 10-degree rotation, people are doing in office also by needle. People have described, which we don't advise for people in India as such. It's always better to take the patient to operation theater, do a comfortable preparation for your patient because it's again an intraocular surgery for these patients. So this is the patient, 1-degree rotation after I did a re-rotation and no change, zero cylinder now. So this is what analysis with eye trace gives you a satisfaction that you have done a correct assessment and a correct achievement for your patient. So this is one patient shows 25-degree rotation. But this rotation, I do only 0.5 diopter change. That means this is a patient maybe had a more spherical power than the cylinder. So therefore, I may not do any assessment for this patient in terms of rotation. May require a different type of correction for these patients. So this is a patient requires 0-degree rotation and change. But if you see into a visual quality was, it was poor visual quality because of ocular surface problems for this patient. The aberration are much more in these cases. It's not only the rotation of a case, it is you have to look for aberrations also for your patients, ocular surface for your patient before you go for rotation for these cases. So this is our comparative study we did for a manual versus image-guided implantation of toric IOL. Use of eye trace gave us the idea looking to the quality of vision for these patients because rotation from the main axis was less than 5 degrees in both the groups. But the quality of vision, which we assess by eye trace in terms of MTF and Stulls ratio, was much better with the image guided systems. So eye trace gives you that assessment for your patient in these areas. The optimization can be done preoperatively by assessing angle alpha, hyaluronic aberrations, calculation of toric owl power. Intraop gel liver caliper might help you in getting a proper access. Most importantly, the post-op analysis of the eye trace gives an assessment of a toric IOL implantation as such. I do for every patient who undergone toric IOL. May have a 6/6 vision also, I still do a toric assessment for these patients and see how much the residual refraction then needed, toric rotation by enhancement software, and takes you through the right way to assess for these patients. So eye trace is really helpful for enhancing your cataract surgery, refractive cataract surgery practice, especially for a newer generation lenses, which requires a absolutely precise outcome for your patient. Thank you for your kind listening.
Thank you, Professor Vidyal. Excellent talk. You are around for the questions, or
I
you have to
have
go?
a commitment.
Okay. If
Any
anybody
question we can,
any question you can ask now. Yeah.
Yeah, that's a good question. We see patient first poster day for all patients. So I do analysis for every patient on day one. Dilate and do first we do undilated refractive analysis, visual acuity, distance near intermediate. Then do a little dilatation for these patients. At least require a 5 millimeter dilatation to good analysis. That's the cutoff. Then do eye trace for all my premium IOL patients. And then if patient vision is less, then you can think of no any assessment if needed, especially if the rotation is much more 10 degrees. And I know that is a mistake by us in terms of our axis orientation. Sometimes it can happen. Then I take the patient next OR, that is after 2 days. So I don't do immediately. I wait for my OR to come because I have OR after every 2 days. So rotation is done very effectively. No addition is there in those patients. And inflammation also settles down. You can manage appropriately. But as I showed one patient of high myopia of the large bag, there is better to wait for slightly longer time, maybe within the next 2 or 3 weeks. If needed, if a bag is too loose, you can put a CTR also at that time to make bag much more rigid. Okay, thank you. Thank you very much. Thank you.
Thank you, sir.
Thank you. Now we have Dr. Amit. He is professor at PGI and doing a lot of good work, excellent work in cornea and refractive surgery. He is going to highlight little basics which we missed after the first talk by Dr. Chintan. He is going to highlight the multi-zone reflection analysis, point spread function, and modulation transfer function. It's important to know the basics to understand and how to use that in improving our results. Professor Amit Gupta.
Thank you, sir, for including me in this very interesting instruction course. So there may be a bit of a repetition. I'll try to minimize that. And these are very important. What makes eye trace different from other aberrometers? That's what this talk is all about. And it's not advancing. Advancing. Wait. I think this is a technical hitch. I'll just try to. देखो. Can we do that? Okay. Yeah. Okay. So if you look at this is the eye trace, you have seen it before. So what makes it so special basically? So what happens is that in the eye trace, we have a series of infrared laser points which are fired into the eye. and these are individually then analyzed. So that is where the eye trace differs. It's an autorefractor, it has a topography, it has a ray tracing aberrometry, it has a pupillometry, it is an autorefractor keratometer, right? And so look at this beam, so and see where it is falling on the retina. So each beam is falling separately and is being analyzed separately. So a set of 64 spots is fired 4 times to generate what is known as the point spread function and the retinal spot diagram. And this is what it contains: all the information about the refraction of the eye, the aberrations of the eye, and the optical and visual function of the eye, both qualitatively and quantitatively. So the sphere and cylinder are obtained through calculations which are based on the Zenik's coefficients. It has a very, very efficient optometer, which is known as the Badal optometer, which is used to generate accurate data. So if we look at the range of the autoref, it is plus minus 15 diopter sphere, plus minus 10 diopters of cylinder, and it can measure through a wide variety of pupillary sizes accurately, both 2.5 to 8 millimeters, and it has an excellent accuracy and reproducibility. So what makes the autoref special in this case? Again, we want the autoref readings to be as physiological as possible. So what it does is that it gives the patient a highly blurred target, plus 7 diopter blurring for emetropic eyes. So this is a featureless target, and 20 pre-examination laser spots are then fired to acquire the data to calculate the patient's spherical equivalent. Then what happens is the target is then moved from the far point to the patient's to a near point plus 1 diopters. So this it so what the patient classically sees, if you sit on the eye trace, I'm sure it will be there in the exhibition. So you'll see a small, relatively featureless, but defocused on the side of plus focus. So this actually gives a very, very accurate reading. There are several studies which have been carried out, and I did my own autoref reading. It is very, very accurate compared to the manifest refraction, so to the tune of less than 0.12 diopters. The condition is that the accommodation, we know, has to be relaxed, and this is where it scores over other autoref instruments. So when we talk about multi-zone refraction analysis, what happens is it gives us different zones at which we can then see the refraction. For example, if the patient comes and says that I have problems with my night vision, especially after refractive or cataract surgery, and it leads to a post-operative dissatisfaction in the patient. So what we can do is we can track these changes. What happens during the daytime? What happens in the evening? So if we take a close look at the refraction of the patient now, as Professor Tityal was saying, any tracy refraction, it is color coded. If it comes in red, it means your red flags should be up, and usually it is something which might require a surgical intervention. It's not going to be corrected just like that. But if you see, as compared with the size of the pupil, you'll see as the pupillary size is increasing, the refractive error is, of course, the main culprit here is the increased spherical aberration in this patient, but the complaint is that of night myopia, and this explains it, and it's very good tool to explain to the patient also, you know. And of course we also know that the larger the pupil, this has a visual simulator. So this has an e which is displayed, but you can talk to the patient, you can show them what is the problem and how we are going to correct that. So in a smaller size pupil, of course, the E will become clearer. So we know that there are different types of 20/20. We want our patients to have the best quality of vision which is possible. Now, if we look at the point spread function, what is point spread function? So it is basically what a point source of light looks to the patient, how it looks. So if it is a very aberrated wavefront, it will be an aberrated point spread function instead of being a very compact kind of a source of light. It is also displayed in a 3D mode. So you want to see something like an Empire State Building. You don't want to see something like the Himalayas spread all over. So there is a very quantitative way that we can express it, because when we quantify things, makes it so much easier for us to analyze it. We may not understand how that quantification is arrived at, but Strahl ratio is the ratio of the peak focal intensities between the aberrated and ideal point spread function. So ideally it should be 1, and the lower the reading it is, we know the worse is the Strahl ratio of the patient, worse is the visual quality of the patient. You just take a look at the Strahl ratio and you know that something is very wrong with the patient. Now, the point spread function is of two types. One is the total point spread function and the higher order point spread function. Like the higher order aberrations, higher order point spread function cannot generally be corrected by conventional means in this patient. So it can be used along with a vision simulator chart to understand and explain the patient's symptoms when we are working up a patient. For example, simple thing, is the patient going to benefit from glasses, spectacles or not? Sometimes it's a very small question, but we are in a fix. So it shows you without spectacles and with spectacles, the kind of point spread function, and it makes us more confident in prescribing just a simple spectacle correction. For example, also in cataract surgery, how the patient's eye is behaving post cataract surgery. Now, another very poorly understood function is a modulation transfer function. Now, we know that we are calculating a contrast of the patient, such a tedious job for us to do. It's we have to spend time explaining to the patient. Here, a 2-second reading gives us a very good idea of what the patient's contrast might be, and that is expressed by the modulation transfer function. So this is derived from the point spread function. It's the eye's ability to transfer the contrast from the image to the retinal plane. So this is basically, this is the contrast sensitivity of the lens system. And this is again one of the units of the visual performance. So modulation ratio is the ratio of the image contrast to the object contrast. So the actual contrast of the object and the image contrast, right? So it comes in this graph, and the contrast is represented by the y-axis, and the spatial frequency is by the x-axis. Now, what do we mean by these terms? The contrast in the spatial frequency, basically, if you see a grating, you will see that as the spatial frequency goes up, the grating becomes finer, closer and closer, till it becomes a blur to the patient. So an eye with a high MTF will be able to see things better, smaller labels better than an eye with a poor MTF. So if we are talking about some area here, it would probably mean you're reading a billboard, and the normal writing would be somewhere in this area, and a smaller label way down in the spatial frequency. Now, this ITIS gives us a red box, and this red box is 40% contrast and 10% spatial frequency. Anything which is above that is considered that the patient's vision is going to be satisfactory. Is my timer? This timer is not on.
Yeah.
What? Can I go? Yes.
Can you wind up, because we are going to.
Okay.
Yeah.
Right. So essentially, so this helps us in making in decision making also in the refractive surgery in these patients. So this is all about, I think, so many other aspects of the eye test are being discussed. This is what I want to talk about. Thank you very much. Any questions, I would be happy to take. Thank you.
Dr. Amit, I just have one question. Can we correlate this MTF with the contrast sensitivity measured by Pelly-Robson or anything?
Yeah, I mean, this is something that we have wanted to do for a long
Yeah.
time. We have done as a part of the thesis.
Yeah.
We have done, but because when you are charting the contrast in these patients, for example, using a functional vision analyzer or things like that, so you know that how the contrast is being charted out, at all the photopic and the cycles,
True.
it's very difficult to correlate with a single value.
Yeah.
It's very, I mean, we are trying to get around to it, but when we are getting the charts, when the patient is actually doing contrast, it is extremely difficult to correlate with the graph which is produced by the eye trace.
Yeah, the reason why I asked this question was that I did a study, it has been published also now, one of the thesis of one of my candidates. We compared the Indian acrylic, hydrophilic acrylic phakic implant with the ICL, and we compared the visual outcome. And we found out that on Pelly-Robson, the contrast was comparable in both the group. But in MTF, the ICL group fared better. And I mean, that is something which.
Yes.
So
I mean,
answer to if answer to that is MTF is purely optical phenomenon, and contrast sensitivity is a neural component also.
True, true.
So the quality of the lens will affect the MTF. Up to the retina, eye acts as an optical system.
Yeah.
So once you are measuring MTF, it is optical system you are measuring, how the light is transmitting. Once you are measuring contrast, it has a neural function also.
Yeah.
So it depends upon that. So
Yeah.
there is a psycho-optical part of contrast sensitivity. So it will be different.
Yeah, that's why I was
So
wondering
it
whether.
depends upon whether the neural pathways are intact,
Yeah,
whether
yeah,
person is having normal
yeah,
diet,
yeah.
all those vitamin D, omega-3
True,
fatty
true.
acids which takes care of neural system, they are okay or not.
Okay.
Yeah.
Yeah.
So that's the answer.
Okay.
Yeah.
That,
Yeah.
that's why I
Please.
was
Thank
just
you.
wondering whether doing MTF will be.
Phenomenon.
Yeah,
And contrast is
yeah,
neural
yeah.
network involved with it. So coming to the last part of the talk, again, how to decipher dysfunctional lens index. This is a new term introduced few years back by one of the authors, and how to measure depth of focus on this, and how to use this depth of focus in planning various IOL and increasing the presbyopia range. And this was introduced by uh, the term DLI, dysfunctional lens syndrome. It is just in Western world just to include or decrease the threshold for doing cataract surgery. They have introduced this and divided into stage one, two, three. In stage one, the lens is still clear and colorless, but it is stiffer and it's not fully able to accommodate due to presbyopic change in the lens, and the aberration profile has changed as already highlighted. The spherical aberration of the lens changes from negative to positive side, and in stage 2 around 50, 60, 56th decade of life, it starts to turn its color into mild yellow. It becomes slightly hazy and affects the patient by making the night vision little difficult, and it is not as good as it should be. And stage 3 is definitely have a cataract, that when the visual acuity goes down beyond less than 2050, and a patient has a vision with or without glare, or which involves visual impairment, and it hinders the daily chores of the patient. So how the eye trace helps us in classifying these patients into different categories. So it's based on it's a new software. It's based on uh, uh, combined opacification in the system as well as higher order in the system, both corneal as well as lens, as I already highlighted. And index is based on higher order aberration, which are again purely optical, and contrast sensitivity, and of course the pupil size, which is very important. And higher numbers are towards normal. The scale is given from 0 to 10. 10 is perfect 10. Up to 5 or 6, you can still do without doing surgery. Like in this case, there's a dysfunction lens index where the score is around 4.76, and rest of the things are okay. This is from the internal aberrations or the opacification. So here one can convince a patient to, and you can show the patient. It's a very good tool. You can say, this is how you look. This is a vision simulation, how you look like, and if you want to look perfectly clear, then you have to do something about it. And this is another patient having 6.6. So here the vision is relatively good, so you can still wait. Otherwise, sometimes become difficult to explain to the patient, should I wait? Or if definitely patient have symptom, night driving complaint and all, you can go ahead. And this is another patient. So here score is 8.47, but here the angle alpha again is very high. So you have to be careful. As of now, everything is fine. It's not an indication for doing a cataract surgery. So it's a sort of DLI, uh, which is not significant. The score is more than 5. And this is another patient where the score is just 2.76. So it shows in red, green, and yellow, just like traffic lights. Red is go ahead, yellow is it's I mean you can just wait, or green is clear signal. You have to wait. So and but in this patient, this quality of vision was partly because of the asymmetric bow tie. Patient had little changes in the cornea also. You can see the asymmetric bow tie on axial map, and here you can see again the internal aberration are too high, you can see very high bars. I won't again highlight. So there are enough paper in the literature which has correlated dysfunctional lens index with the Scheimpflug lens densitometry, and this is the paper which has given the score, and which says that 10 is a perfect score, and DLI has stronger correlation with best corrected distance visual acuity as compared to the LOX classification. So CDA is more important than the LOX 3 classification. And this is very important, the depth of focus. So this is about analysis of pseudo accommodation in aspheric or extended depth of focus IOL using ray tracing aberrometry. This is the depth of focus of the two eye. You can use this tool to increase the depth of focus in two eyes so that the range of accommodation increases. As we all know, EDOF IOLs have a limited range of defocus, varying from 0.5, 0.75 to the recent IOLs have 1.5 or maybe 2.25, the recent one. So we can combine a mini or a micro monovision in these cases so that you can avoid multifocal and the photic phenomenon, as well as increase to have a good distant, intermediate, and near vision. So this is various types of press papillary are available. I mean, it's a pseudo accommodation. This is how we have evolved using various types of multifocal, trifocal, now EDOF, and now hybrid monofocal with EDOF IOLs. I won't go into details. So there are different types of press papillary correcting IOLs, and these are the various types of based on different principle of EDOF. We have Minival, the Vivity, IHANS, Technis Synergy. Basically, there are four principles: pinhole effect, diffractive, and based on asphericity. These are the main principle on which these EDOF IOLs are based. But what the patient is concerned about is quality of vision. He shouldn't have any photic phenomenon. His defocus curve should be large, and there should be good contrast and good reading performance. And most of the time, he wants to be spectacle free. So these are the recent IOLs, EDOF IOLs with different range of extended depth of focus. With this around zero point 0.5, this one, this is 0, this is around 0.5, but even aspheric IOL around zero point 0.5 diopter of pseudo accommodation or a defocus curve if we compare. So there's hardly any difference between two. This one has around 1.25 diopter of defocus, and this lens has around 1.25, around 1.5. So we can use a micro monovision in these cases to extend the uh, depth of focus, binocular depth of focus. So we don't use a monovision because we don't want to have a monocular suppression. So we usually go with the mini monovision or an offset of around one diopter between the two eye. How we do that? This machine helps us to do that. So this is the point spread function of different IOLs. As we go, the diffractive type of EDOF, they have a large point spread function, so they are not, the quality of vision is not that good. So as compared to the other type of IOL which are non-diffractive. So expanding the spectrum of these IOLs, we can by mini monovision we can increase the distance, intermediate, and near vision in these eye. This is one such case. We have targeted emetropia in the dominant eye and a sort of myopia in the other eye, 0.75. So this is the individual depth of focus, 0.67 and around 0.75. But once we do it on eye trace individual defocus curves combined together, we increase the depth of focus of both eyes to the range of 1.8 diopters. So patient will be able to see almost clearly up to uh, one intermediate distance. All right. So that's how, and you can decide the offset also. The offset should be that if in one eye it's emetropia, the curve of here it should fall somewhere with at the midpoint. Because at 50% this thing, you don't have a suppression, and the functional vision continues, the functional vision. So but we have seen that the subjective depth of focus is always far better than the this digital or the what the machine gives, because they have various clues, monocular clues, multifocality of the cornea, the pupillary diameter, all those things adds on and increase the depth of focus. So this is another case to show the same thing. In the other eye we targeted 1.15 diopter, and we have increased the range of defocus to 2.1 diopter. This is what the eye has. And subjective depth of focus is much more. The functional one is around 2 diopter. Here it is the digital one is this one, but the functional or the subjective one is more than where we get a 50% vision. It's much more. So with the A1 EMV, it's advocated to have a just I'll finish. It has a range of EDOF of 1.25 diopter, and this the lens devised by Australian. Our this what is his name? I'm forgetting the name. The famous. Uh, okay, okay, all right. So again, here we target an offset of one diopter, and the advantage of this lens is again this lens is aspheric neutral, and this lens even cover, even if you target myopia of zero point 0.5 diopter in emetropic eye or distant dominant eye, this even then you get a even you get a 6-6 vision, because the depth of focus extends to the positive side also, so that you are utilizing that quality of the lens in increasing the depth of focus.
Sir, I
So
think the time for our session is
okay,
up. We have the
so
next people waiting.
so this is what I wanted to explain. So in this, you can get around almost 3 diopter of depth of focus with this lens, and this is the binocular depth of focus, which is much larger than even Vivity. So you have another IOL ICRL cert, which has almost 1.75 EDOF. So you can have almost 3.5 diopter in both the IOLs, and this is about the Vivity. Vivity also does the same thing. So another, so basically we can use this machine to select the second lens, how much we want to increase the without sacrificing the binocular vision. We don't want a suppression of the eye in depth of focus. We want a binocular vision. Thank you so much. If there any question, I think we have over.
Questions we can take
We can have
later, I think, because the next
Yeah.
session.
Eye tracing should be done in undilated pupil or in dilated pupil. Examination should be done
Yeah.
in a dilated pupil or in undilated pupil.
It should be done in undilated pupil, because
Okay.
that is the functional.
Okay.
Yeah, because
And
once we
regarding
do an eye trace, we go scotopic vision, mesopic vision, and photopic vision. All are part of our daily life. Huh? Dawn and dusk is mesopic. Scotopic vision is night vision.
even post-operative analysis for toric, that time
For
also we should
that,
not
it can be
dilate.
mid-dilated, the toric check.
Toric check we require dilated.
Yeah.
Thank you.
Are there any other questions? Thank you very much. I'll thank all the speakers for their contribution and being here early in the morning and making it a success. And also thank the audience for their patience hearing and be here till the end of the session. Thank you so much. We can have a photograph, quick.